Yes, I want
Oops.
to thank Jean again and again and again for doing this for us every year. Laura just emailed the handouts. Thank you, Laura. Um, and we're so happy to have you today. We're always happy to have you. We love you. And you're exclusively endorsed by the Broward County Medical Association and have been for more years than I can remember. So thank you, our honored guest, Jean
Thank
Acevedo.
you. Thank you, Cynthia. All right, good afternoon, everybody. Nice to see that so many of you are trying to figure out, all right, what's different this year? So let's see. There's me, blah, 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 right? Compliance, coding consultant, been around for a long time. Disclaimer, this time of year for this presentation, I always stop at the disclaimer. And that's because it's all of what, January 20th. Everything I'm going to talk about is about 20 days old. So for a lot of things, there haven't been, from the Medicare program, there haven't been MedLearn Matters articles, or they haven't issued transmittals or anything that would tell us more than what I was able to discern from the actual physician fee schedule rule for 2022. And my, reading of the code books, right? So I've done the best that I can to translate all of that into understandable verbiage, but be on the lookout for additional information from CMS, other payers, as to how they interpret some of these things. And if anybody doesn't have a current CPT or HCPCS book, well, first of all, shame on you. There needs to be at least one in the office, unless you've got really good electronic resources, because you'll hear me say it till you're probably tired of it. In addition to looking at the CPT codes each year, what's changed, you really, really, really need to be paying attention to the guidelines, parenthetical notes, et cetera. And as I go through what I'm going to cover today, I am no substitute for any of those books. I don't discuss every code change. It'd be impossible. We'd be here all day. And I don't necessarily have entire definitions down on my slides. They may be abbreviated, et cetera. So, and that having been said, so when it comes to the codes, I'm going to, for any of you who've attended this talk that I do every year, you know that I'm going to go from the beginning of the CPT code book to the end, point out some of the highlights to hopefully make sure that you are aware. And for CBT, that's, little things such as change for that nurse visit code for the first time in 20 some odd years, principal care management for the specialists. And then again, like I said, a section by section review and some HCPCS codes, not a lot. Definitely paying attention to modifier changes this year. And then because ICD-10 has really been in place for 3 months already for 2022, I wasn't going to go through anything except that 2 weeks ago, maybe at the most, there was a brand new set of ICD-10 codes relating to COVID. So I said, oops, those will not be in the folks' ICD-10 code books. So let me interject that. And then the rest of the F5, 6 areas here are all from the physician fee schedule rule. So that being said, I'm going to get started. And also know that I don't know the specialties of my audience. So you are permitted to zone out if I talk about orthopedists. You go, well, that doesn't help me. I'm a nephrology practice. That's okay. You can zone out for those 5 minutes, right? But like I said, I never know. All right. So here's the highlights for CPT. And just so you know, there were about 250 new codes this year. That's a substantial amount. 5 new ones in evaluation and management, and that mainly has to do with the principal care management codes. Anesthesia had a handful of code changes this year, which is unusual for anesthesia. I can do years in a row and not have any updates for anesthesiology. Surgery, which of course encompasses every specialty other than, well, actually every specialty, because even a minor skin tag removal, right, is surgery. So radiology, as you can see, not much, 4 new codes. Pathology and lab, all across the book, the section of the book, there are new codes. Not going to really go over too many because I didn't really find ones that on a day-to-day basis, at least in my experience, that were going to impact physician practices, except for anybody who is actually or has a clinical pathologist in their practice. I'm going to stop and talk about the changes there. And of course, the medicine section, which is the catch-all for everything that doesn't have enough to have its own section. Category 3 codes. Look at this number, 72 category 3 codes. And I'll speak more about the importance of paying attention to this code set, this subsection of the code sets every year. And an awful lot of deleted codes. Most of the deleted category 3 codes you'll see are because they have actually been submitted on claims sufficiently enough over the last like 5 years for the AMA to make what I call real CPT codes, category 1 CPT codes. So it's not that they've been deleted, but they've been substituted with category 1 CPT, right? All right. So we'll take each of those sections. Evaluation and management. And let's see, let me get rid of a nice little picture for one or two of you so I don't have my slides blocked. All right, evaluation and management. Well, you all know, I'm sure, that last year the office and other outpatient visit codes 99202 through 15 were changed dramatically. What hadn't changed, though, was 99211, that infamous nurse visit code. And as the AMA looked at the definition of 99211, they realized that it didn't fit anymore with, how they had changed the office visit coding. So here's the new definition, including the verbiage, redlined it, put a line through it, for what's been taken out, and doesn't really change anything. You know, this is an office visit performed by your nurse, medical assistant, for a problem that the doctor has asked your nurse to see. You know, maybe it's a blood pressure check, patient in a urology office that is called with a UTI, and the doctor tells the nurse, well, have Jean come in, do a urine dipstick and call me with the results, and we'll see if we need to treat her. So I do go in, you take my history, whether I have burning, frequency, blood in my urine, etc. You do the urine dipstick, you call the doctor with the results, and he calls in a script for some sulfur antibiotic, right? So your little nurse visit. And the only reason they changed this was, again, to make it the definition of 99211 more in line with the other office visit codes. So, all right, that's it for your normal E&M codes. Point to make, though, is that I expect, let's see if I'm right next year, that we are going to see some dramatic changes to other evaluation and management service codes, maybe consultations or hospital visits in 2023 that hopefully actually will kind of mirror what we saw last year. All right. Other area in the evaluation and management section is remote physiologic monitoring. And pretty much what happened here were some guideline revisions. And some of that was prompted because there were now also, and no, I am not one to yet be able to well explain the difference. We have this remote physiologic monitoring. And then more in the back of the book in the medicine section, we have remote therapeutic monitoring. Yeah, don't they sound pretty much the same? In all honesty, as I've indicated, it's confused me as well. So the guidelines for anybody who's doing remote physiologic monitoring or treatment management have been changed to make sure that it's really clear for the time-based codes like 99457, which is the first 20 minutes, and 99458, each additional 20 minutes, that you understand that you have to have completed the full 20 minutes. So anybody who's used to billing reporting time-based CPT codes might think about, well, wait, in the introductory section of CPT, there's a little subheading for time, and it may be pretty long, but basically what it says is you can bill the code once you've passed the provider has passed the midpoint, right? So if it's each 15 minutes and I've gotten to 8 minutes for that service, I've now passed the midpoint, I can bill that code. But it also says, unless there are specific code guidelines along with the code that you're trying to report. And remote monitoring is one of those that you cannot use the general past the midpoint rule for CPT. Just as, well, actually, most of the care management codes are like that. So it's really clear, it has to be a full 20 minutes. And also, since they are remote physiological monitoring treatment management services, in addition to whatever the device is that the patient is using, that must be an FDA approved device, et cetera, and whoever it is in the practice, and you can see it's clinical staff, physician, or the non-physician practitioner. So even just your clinical staff, there must be documentation that the results are being used to help manage the patient, right? So if there is some, say, remote heart monitoring for blood pressure that is being done, well, how is that impacting the doctor's treatment of the patient, right? Something I would imagine, because I haven't seen any good clinical examples with the example I just gave, is to maybe at least the record shows whatever the results were for the monitoring, obviously the time, in at least 20 minutes. And then that, so according to Dr. Peterson, the patient should remain on the same dose of their antihypertensive medicines, right? So that it's clear that the monitoring results that were provided have impacted the treatment. So that's really clear in CPT this year. And I've already kind of alluded to care management services mainly because I believe that principal care management, which last year had HCPCS codes, or the deleted code sets, because now it's CPT, as the AMA brought the principal care management services into the care management section of CPT, they needed to update and revise the guidelines and defining a care plan, et cetera. So if you're reporting any chronic care management or principal care management, you need to make sure that in this section of the book that you really read the guidelines to make sure that you are reporting correctly and that the documentation supports the codes, so that should Medicare or any other payer decide to ask for records, you won't find yourself in the category of, oh my goodness, what do you mean I owe you money? I hate when that happens. So to help you understand what that might include, and this is what's in CPT, but it also reflects some of the deficiencies I've seen when I've actually looked at documentation for some of the care management services. So obviously, if there's care management, there needs to be a plan of care, right? And in that plan of care, you need to make sure that somebody needs to put themselves on mute, if you would, please. If you would all put yourselves on mute so that little side noises don't get in the way, that would be greatly appreciated. Thanks. That should have been part of my initial housekeeping. So in that plan of treatment, that care plan, there needs to be specific and achievable goals for each condition that you're doing the care management for. So if you think about it, chronic care management, the patient must have at least 2 chronic conditions, yada, yada, right? So if you're choosing, say, hypertension and hyperlipidemia, what are the goals for the hypertension? What are the goals for the hyperlipidemia? And as you're choosing, or your doctors are, the 2 conditions, say, for chronic care management, make sure that they are actually conditions where the patient needs to have goals. So what do I mean by that? I was doing a review of one organization's chronic care management, and they had a great assessment tool that the staff were using to try to pinpoint the chronic problems and the patient goals, et cetera. But for some reason, they kept choosing the 2 conditions that the care plan was about of the first 2 ICD-10 codes, or first 2 listed conditions in the doctor's impression. And it happened to be hypertension and hyperlipidemia. And as I read through the entire assessment, the patient, both of those conditions were well controlled. When the questions were, well, what are your goals, right? I said, well, I don't really have anything because everything's perfect, right? And I'm like, okay, so there's no medical necessity then for chronic care management because there's nothing to manage that's already managed. But then as I read through the document, I saw that the patient had some form of arthritis in which she had almost daily pain. She had some joint swelling, et cetera. And I remember thinking, why isn't this one of the 2 conditions that they're doing the chronic care management for? This is something where the patient should and could and would probably love to have goals about decreasing her pain and what can I do for the swelling, et cetera. So make sure that one, you have goals, that they relate to a problem that's actually problematic, and that they are achievable, right? Objective, measurable goals. The entire care plan needs to be reviewed or revised at least annually. So if you had started a patient in 2021 on chronic care management, or if you're specialist principal care management and you did it in March, if you haven't documented, if the doctor hasn't documented that she's reviewed and or revised the care plan and since then, within the next month and a half, that needs to happen and be documented, right? Another thing that is not always intuitive to folks to do is to make sure that a copy of that care plan is given to the patient. This is actually a good use of your electronic medical record, that portal, right? Should make it easy to just upload the portal. If the patient is interested in chronic or principal care management, they're probably a patient who might actually use the portal, especially if they know that that's where they can get this document, right? So, and then the other thing, and it's not for chronic care management or principal care management, but that transitional care management that a lot of primary care doctors are doing when the patient's been an inpatient. Remember those two codes, 99495 and 99496, if I remember correctly. You know, I've done everything and seen the patient within 7 days, and the patient's condition is of high complexity, or seeing the patient within 14 days and it's moderate complexity. Until now, there's never been anything for that code set to tell you how do you determine moderate or high complexity for transitional care management. There's been no table of risk or anything like that, right? So now it tells you that you need to use the definition that evaluation and management services have. And anybody see me grinning from ear to ear? I mean, that's what I feel like I should be doing, because with the changes for office visits that started last year, there are now 2 different ways to evaluate the medical decision-making complexity. So it still doesn't tell you which one, but know that one of the guidelines is what you have to use. So those 4 things, I've pulled them out because they are 4 things that when I review care management services for physicians, that I see 1 or more of them not documented. So I want you to keep the doctor's revenue safe. Principal care management, which I've mentioned, and remember what this is for those of you who don't know what it is. The government 2 years ago realized that a lot of specialists were saying, hey, this chronic care management is great, but I have to be treating at least 2 chronic conditions. I'm a cardiologist. I'm not taking care of their chronic kidney disease or their rheumatoid arthritis. I'm only dealing with their AFib. So this isn't helpful for me. Yet I have patients that whether myself or my clinical staff should be reaching out to and having conversations or emails or through the portal on a routine basis during the month that would total at least a half an hour over the month to help manage their chronic condition. So CMS created principal care management. And no, if you're a specialist, you don't have to worry about stepping on the toes of the primary doc who's reporting chronic care management, because it doesn't interfere. The primary care physician could be doing chronic care management. The cardiologist could be doing principal care management for the AFib. The nephrologist could be doing principal care management for the same patient in the same month as the other 2 for the end-stage renal disease, right? If obviously all of it has to be medically necessary, but they don't, one doesn't discount the other. So that's a good thing. But it was HCPCS codes. Now they're CPT. So you'll see the new CPT codes in the CPT code book. And there are 2 sets similarly to chronic care management. 99424 and 99425 are the first, and then each additional 30 minutes when personally provided, the time spent personally provided by the physician or the nurse practitioner or the physician assistant, or 99426 and 99427 for the first 30, and then each additional 30 minutes by the office's clinical staff. Same rules apply as chronic care management, needs to be a care plan, et cetera, and everything that I said on another slide. If you're a specialist, stop and think about patients that you have that you know get a lot of touch points, I'm going to call it, right, in the course of a month. Maybe not every month. That's fine. You don't have to build these stuff every month, right? And consider whether or not this isn't a service you would like and should be providing. Okay, that's really all from E&M. I'm going to stop for a second, only because I see, okay, never mind. Just going to see what was in chat, but it was Cynthia asking everybody to mute themselves. Thank you, Cynthia. All right, anesthesia. Not much, but definite change. There are 6 new codes in a whole new family of anesthesia. So this is only obviously for the anesthesiologist, but we do now have 01937 through 01942 for radiologic procedures, percutaneous image guided for anatomical locations of the spine. And as you see, they are area of the spine based, right? So it's if you're an anesthesiologist and you hadn't realized you had new codes, now's the time to make note. Go to your CPT code book and make sure if there are any other guidelines or anything that you would need to know to implement these. Oops, I must have gone the wrong direction. There we go. All right, surgery section. About 24 new codes, my count, when I went through this section of the book. There's this one new definition in the general surgery guideline section that I found interesting because that same definition is in 2 other sections of the CPT code book. So I think the AMA is trying to make sure that everybody understands what the heck is a foreign body or an implant. And in reading additional information from the AMA, they are under the impression, based on how claims are submitted, and then what the records actually show, that not everybody understands what especially a foreign body is. So here's what it says. Here's what you need to know. An object intentionally placed by a physician or other qualified healthcare professional, so that's those nurse practitioners, PAs, for any purpose is considered an implant. Makes sense. An object that is unintentionally placed due to trauma or ingestion is considered a foreign body. If an implant or any part of one has moved from its original position or is structurally broken so it no longer serves its intended purpose or presents a hazard to the patient, it now qualifies as a foreign body from a coding perspective, right? So, and unless CPT instructions tell you otherwise, or a specific CPT code exists to describe it, the removal of that broken CPT code exists to describe the removal of that broken or moved implant. Excuse me. So what's the main intention here is to make sure that you understand that a foreign body is not an eyelash in the eye. It's not a hair, your own hair in the ear. So your doctors who may have, not saying anybody did, but may have coded a removal of foreign body code when it was something, the foreign body was actually part of the patient's body, i.e. not foreign, right? You're now on notice, whether I said it or not, you should have the code book. You're held accountable to what's in the current year's code book. It's pretty straightforward now. All right. In the integumentary section, there are some revised guidelines on repair. And this is very similar to me, the whole thought process of the AMA as the definition of a foreign body or an implant was. As they have seen claims, excuse me, or spoken to payers on what payers see in the documentation when they request it, they've realized that folks have been reporting a repair code when there have been no sutures or anything that really supports the use of a separate code for a closure. So to make sure you understand, they've now revised the guidelines and some definitions to make it clearer. So under repair itself in the guidelines of integumentary, use the codes in the section to designate wound closure utilizing sutures, staples, or tissue adhesives, either singly or in combination with each other or in combination with adhesive strips. So that's the general definition of a repair. So before even looking to see what's a simple repair, a complex repair, a repair itself, this definition should tell you Oh, it has to have, excuse me, sutures or staples or some type of tissue adhesive. But if it's just like a butterfly or some type of adhesive strips, do not report a repair code. Also, chemical cauterization, electrocauterization, as the sole repair material are included in the appropriate E&M code. So even cauterization is not considered a repair from a coding perspective, to use one of the repair codes. And then just to give you an idea, so simple repair has been revised so that it says is used when the wound is superficial and requires simple one-layer closure. So one-layer closure, sutures, staples, hemostasis, and local or topical anesthesia when performed are not reported separately, right? So if there aren't any sutures, there aren't any staples, there aren't any, the heck was the other one? Tissue adhesives. It's not a repair code, not even a simple one. Just include the complexity of the work in your E&M code, right? So wait, there's a part of this little thing that's still in my view. How do I get rid of that? Oh, now I see all the people. Hello, people. Uh-oh, sorry. My little cockapoo has spotted someone must be walking down my cul-de-sac. All right. All right. So did I finish that one? Yeah. All right. Musculoskeletal. So that's really it. There weren't that many code changes in integumentary, but definitely definition and guideline changes that are important. Musculoskeletal, shocker, more guideline changes. So I think I said it at the beginning. It is not enough to just figure out what are the new codes that my doctor uses. Miss Zoe. Sorry, I'm going to stay quiet for a minute until she's got this out of her system. She's all of 9.5 pounds. She's cute as a button. And she doesn't know she's only 9.5 pounds. She is protecting me with her fluffy little life. All right, I think that's over. You must go to the guideline section. So when I get my new CPT code book each year, I do two things. I go to the back of the book where they list all the new, all the added, revised, and deleted codes. And I know what sections that I have doctors I work with that they bill under, right? So obviously E&M, so the 99 codes, I'm always looking to see if there's something new there. Orthopedists, I'm going to look at the 20,000 codes, et cetera, right? And I can spot them in the list because the new codes have a red dot, et cetera. All right. And then after I've made note of what these changes are, these technical code changes, I go to those sections of the book and I literally scan through the narrative guidelines. And I don't know about your CPT code book, but in mine, the guideline revisions or new sections, the font is a pale green. So I can spot a half a paragraph in the middle of old, right, still in effect guidelines that, oh, this has changed. And when you spot guideline changes, it's not enough for the manager or billing and coding to understand it. You should really print that out, make a copy, and give it to your doctors, your non-physician practitioners, because if you think about just what we just talked about with repair, who needs to know? More important than even coding and billing, right, is the clinician, so that they don't inadvertently submit a code for even a simple repair for something that just should have been included in the medical decision-making for their office visit code. Right? So
Jean,
really, yes.
we're only seeing people now. We're not seeing the screen with the.
Okay. So let me see what happened here. Let me go back.
Thank you.
Sure. Thank you, Cynthia. So what happened? Where is what happened to Zoom? All right, let me go back and see what happened. Where's my share screen? Somehow it stopped itself. Can you see it now?
Yes, ma'am. Thank you.
No, thank you. The last thing I want is for people to say, what is she talking about? All right. So the introductory guidelines in musculoskeletal have changed as well. And for orthopedists, this changed significantly because there are whole new definitions and guidelines for cast or splint application, removal, etc. And it's really made it clear that the couple of bullets that I have here, the application and removal of the first cast splint or traction device is included in all services in the musculoskeletal section of the CPT code book. Right. So if you're coding something in the musculoskeletal section of the book, do not try to or not attempt to report a second code for any type of application or removal of that first cast splint or traction device. If a cast is removed by someone other than the provider who applied it, then obviously you can report a cast removal code. Everybody should have known that. That's one of the more logical things. Then also subsequent replacement of a cast splint or strapping or traction device during or after the global period may also be reported separately, and that makes sense. So don't miss out on that billing opportunity if you're an orthopedist. But then some other things, also letting everybody know that, hey, these codes, these repair codes are meant to be used based on the type of treatment, has nothing to do with whether or not the fracture is an open fracture, a closed fracture. It's what kind of treatment was it, right? So I think once I had a closed fracture with open treatment, so the repair code, I don't know what it looked like, what code was used, but it should have been an open treatment code, right? And then they'll also start talking about a situation that through the years, I've gotten an awful lot of questions. So Jean, what do we code if the patient is seen in the emergency department and we just put a splint on or something till the patient can be seen by the orthopedist? Do we code fracture care? Well, CPT now really addresses that so that the temporary placement of a cast splint that's put on, say, in the emergency department until the patient can be seen by the surgeon is not a billable service. You just would include it. Think about the repair with a Band-Aid, right? In the evaluation and management code. So orthopedists, ED docs that do any fracture care really need to review the guidelines more so than any codes in the musculoskeletal section. And then just reporting a fracture or dislocation treatment codes. There's some basic instructions on the treatment that didn't exist before, that is brand new and definitely speaks to the split surgical care environment where the person providing the initial treatment isn't going to be providing subsequent treatment. So that happens a lot here in our wonderful sunny state of Florida. The patients had their hip replacement, just say, right? In New Jersey, comes down here to spend January and February in the warmer weather, and of course goes to an orthopedist here, right, for her post-op care, right? Split surgical services. So it addresses all of that. Right? So anybody who's doing any of that type of care really needs to address that section of the book. And then let me just check. How can I confirm on? Okay, no, so I'm not going to pay any attention anymore to the chat because it's just administrative stuff. I'll look at the end, guys. All right, so cardiovascular. And I've got to say, and many of you have probably heard me say this each year, who's the cardiologist that has really gotten stuck in the craw of the CPT editorial panel? Because a year doesn't go by where there aren't substantive changes to the cardiovascular system codes, and then in the medicine section, the cardiology codes, and this year is no exception, especially for any of the interventionalists that do pacemakers or implantable defibrillators, the EP docs, et cetera. So, and this year there are new codes, revised codes, a whole new subsection, endovascular repair of congestive heart and vascular defects, and new codes and guidelines there. Too many revisions, additions, and deletions to lend itself to what I'm doing today as a general, right, update. But the thing that I actually put in the slide, because I didn't want to forget to say it, because there are so many changes, is that if you're a cardiologist or you're working in a cardiology practice this is one of those years where it'd be well worth the small investment, $74, 60 something dollars, and get the AMA's CPT changes for 2022. That's the little book, excuse me, that gives you 3 things for every new and substantively revised code. 1, what's the rationale? Why did we do it? Why did the AMA do it? 2, what's a clinical example for this? This is something new, or a new code, or a new way of reporting this. What's the patient look like? And 3, almost like a sample procedure documentation, right? And if you get that book for the coders and billers, yeah, it's interesting. And yes, I got mine. I wouldn't do this presentation without it. Make sure that you share it with your providers, because if anybody needs to understand, okay, how do I apply this new code? What does it really mean? It's the person who's actually performing the service, and the CPT changes each year is the definitive, most easily understood document for that. So I'm like, you can order it on Amazon. All right, and I'll probably say it again before we're finished. In the digestive system, well, this code isn't really for gastroenterologists, I don't think, because this new code 42975 is drug-induced sleep endoscopy with dynamic evaluation of velum, pharynx, tongue base, and larynx for evaluation of sleep-disordered breathing flexible diagnostic. So doctors have been doing this procedure, I believe probably mostly sleep physicians, whether neuro or otolaryngology. And they've been, because there was no code, reporting the flexible laryngoscopy code 31575 or nasal or sinus endoscopy, so like nasal 31231, none of which really describe the procedure. The procedure is much more in depth than either of those codes are intended. So the AMA created this new code, and before anybody says, oh, good, we do sleep studies, we could do that in our little sleep lab. The AMA is also pretty clear that this happens under anesthesia in an operative setting. So it's only for those patients going to the surgical suite. But interesting, right? All right, for urologists, some changes, 1 or 2, not a lot. Urologists usually get off pretty easy. So there were some category 3 codes, the alphanumeric T codes, I like to call them new technology codes, that have been deleted. Remember that list of, what was it, 20 some odd or 30 category 3 codes that have been deleted? And I said most of them have been deleted because there are now new CPT category 1 codes. So there are a few category 3 codes converted to 53451 through 53455 to report periurethral transperineal balloon continence device procedures. There are revisions to the repair revision of male genitalia penis hypospadias procedure codes 54340 through 52. And that's really all I could spot for urology. For GYN, there's a code that was deleted, 59135, surgical treatment of ectopic pregnancy, interstitial, uterine pregnancy requiring total hysterectomy, deleted because nobody's billing it anymore. Right? So that's another reason why codes will be deleted, right? It's like the utilization isn't worth the AMA maintaining the code and making sure it accurately represents the procedure. So that's really it in that section. In the nervous section, there are 2 new codes to report laser interstitial thermal therapy for treatment of intracranial lesions, revised guidelines for spine and spinal cord injection, drainage, and aspiration procedures. And a lot of this has to do with what to report and what not to report when there is contrast, fluoroscopy, et cetera, in the procedure, and when you can report fluoroscopic guidance like 77003. So any of the neurologists or anything should be doing these type of procedures should be cognizant of this. For the ophthalmologist, there's an interesting new code set. So there are some new category 1 codes, 66989 and 66991, to report the insertion procedure for the placement of an anterior segment aqueous drainage device at the same time of cataract surgery. So that's been being done, this additional implantation of the drainage device during cataract surgery, but now there are combo codes to report it and report it correctly. And since it's the first time there have been a code set like this, there are new guidelines, new parenthetical notes. So don't just pick up the codes. Make sure that you've read and understood and disseminate the information for, okay, and when are we supposed to use this if we use it to use it correctly? And also a new code 68941 for insertion of a drug-eluting implant, including punctal dilation when performed into lacrimal caniculus each. So no, it's each, right? So, and this was another example of a category 3 code that was deleted and now is a category 1 code. So I keep saying it, so let me give you a little context. So the category 3 codes, those alphanumeric ones, and if you notice, they have one thing in common. They all end in a T. Whether it's a specialty society, a device manufacturer, someone has, or some entity has basically petitioned, in my words, the AMA for, hey, we need a code for this new way of doing something, this new technology, et cetera. And it isn't something that is so widespread that it meets the requirements the AMA has for a regular, i.e. category 1 CPT code book. So let's say that they approve it, it gets a new technology category 3 code, goes in the back of the book, and it stays there for up to 5 years. If it's used enough, like some of the example here, the category 3 code gets deleted and we have a brand new CPT code book, or a brand new CPT code, right? Good thing, because not every payer covers every category 3 code, but most of them cover every category 1 code, right? And so it's important that they be used, i.e. reported on the claims when your doctors perform whatever it is that code describes, so that it doesn't just go away, because if it's not used enough, it just gets deleted. They're not there for more than 5 years. And so really important that not only do you check for new revised codes in your category 1, so are there any codes in the 60,000 code range, blah, blah, but that you go to category 3. The difficult thing about that code set is that it's not organized like by systems or anything, right? So you can't go into the neurology section and go into the otolaryngology section like you can in category 1. But if your book looks anything like mine, you can easily scan through and find the codes that have the red dot that say it's a new code, right? Really, really, really important that they be used because someone has made an effort to get them approved. And then in the auditory system section, there are revised and new codes to report magnetic transcutaneous attachment to an external speech processor for implementation or revision or replacement of an osseointegrated implant. So obviously another surgical procedure for the otolaryngologist. All right, that's it for the highlights for surgery. Radiology, 4 new codes, but also a couple of headings, changes, definitions, and look at that. Because there are indeed some codes in the radiology section that have to do with foreign bodies or implants, that same definition that I showed you back on slide 16, you'll also find it in the introductory language to this section of the code book. And there's one more place it'll pop up. So check the radiology section for new category 3 codes as well. And by that, even though, no, this isn't the category 3 section, but because there are category 3 codes, several of them that impact radiology, in the parenthetical notes underneath your CPT-1 codes, you'll find reference to the category 3 codes to either use them or don't use it in conjunction with, et cetera. So pay attention to those. And then the only new codes that I could find in the radiology section were the trabecular bone score procedure codes 77089 through 92. So if you're doing any of those, or you work with an imaging center that does, there now is something that there are codes to describe them. Okay, pathology and lab. 30 some odd new codes scattered throughout the entire section of the book. And as I mentioned at the beginning, not enough in any one area for me to really comment on. I didn't see any that make me think, oh, if a doctor has an in-office lab, she may be doing that, right? To bring up those codes. But this little change drew my attention. So there are some pathologists that provide clinical consultations, right? Not a shocker. It's fairly common in this specialty. But the entire code set, guidelines, et cetera, for reporting pathology clinical consultation has been overhauled totally. There are new subheadings, new guidelines. Some old guidelines have been revised. And what's really interesting with these new codes there, which are 80503 through 80506, there are new ways to choose the codes. Now, they're going to sound a lot like your office visit codes, because the clinical pathologists are to choose them based on either medical decision-making complexity or how much time they spent. Sounds like office visits, right? Except that the time for each of the 80,000 codes doesn't look anything like your 99214, right? Not surprising. Little different type of work. The pathologist is not actually seeing the patient. And the medical decision-making has nothing to do with any way you determine complexity for an office visit or a hospital visit or anything else. So there's a whole new table in this section for the clinical pathologist to use. And it's fascinating, actually. So if you have a clinical pathologist, for chance, in a multi-specialty group you're in, or if your doctor has a buddy who's a clinical pathologist, someone needs to point these doctors to this section of the code book, because today they're not doing it right unless they are aware of that. And they're going to get either denials or they're going to get audit requests and they won't pass because they were like, what the heck? I didn't know all this had changed. Right? So, all right. That's it in those 4 sections of the book. Medicine. We're drawn to the end of the coding section. So, oh yeah, in the guidelines, surprise, guess what has been updated in the guidelines? You got it. That definition of a foreign body and an implant has also been inserted here. As I said at the beginning of the surgical section, when I showed you the full definition, AMA is making sure that there's no excuse why someone could say, but I thought that was a foreign body, when I had to spend time getting that hair out of the patient's ear that had fallen in from their head. Nope, not a foreign body. All right. Well, where you'll find substantive changes in medicine, the immunization administration of vaccine and toxoids section. Guidelines have been revised primarily, other than guidelines for COVID vaccines, right, which have been coming out all in 2021, right, but now we're in the book. But the administration of vaccines has had always 2 different code sets, 90460 and 61, where there's been counseling of the patient or the patient's parent, if it's a child, on the vaccine, right? And 90471 and 74, where the vaccine is administered and there's no counseling. So I'm actually very pleased that the AMA has clarified what it means to provide counseling, because I've done chart reviews for pediatricians where I've seen the 90460 or 61 codes so that there's counseling provided. And the only documentation of the counseling is the copy of the sheet with side effects, et cetera, right? That was handed to the mom. And I've always said, I don't know, there's nothing to really tell me, but it doesn't seem like you'd get paid more just for handing a piece of paper to someone. And you, doctor, didn't even hand it, your MA did. So the AMA has apparently also gotten wind that that was the way a lot of doctors thought had to be. So to report the 90460 or 61, only when the physician or the non-physician practitioners, so no office clinical staff, provides face-to-face, the F2F is my little abbreviation, face-to-face counseling of the patient or the family during the administration of a vaccine. Not coronavirus, obviously those have their own administration codes, et cetera. So there needs to be documentation of the conversation, right, that the doctor, nurse practitioner, PA had, right, to bill those. And if there wasn't any, nothing wrong, not everybody needs counseling each time, then the practice should be reporting 90471 to 74 for the administration of a vaccine without counseling, right? So, and then, of course, even though these codes have been coming out all of last year, they're included in this section are all the new codes for the administration of COVID vaccines. And there's a great little table in there and all, because these codes, if you've not been doing this, so you haven't seen them, there's a code for the first shot of Pfizer. There's another code for the first shot of Moderna, et cetera. So there's a code for the manufacturer of the vaccine. Then there's within that, there's a code for, is it the first code, is it the second shot, the third shot, not a booster. Some patients, due to a poor immune system, have been getting a third shot. So where you and I might get 2 to be fully vaccinated, right? Some patients have needed 3. And then, of course, a separate one for the actual booster. So for me, the third shot for the patients who are immunocompromised might be their actual 4th shot, but the actual booster. So it's by vaccine manufacturer and which shot was it, right? So there are a lot of different codes for this. And it makes sense. These are new, right? Our public health authorities in this country need to be tracking who's getting what. And then are there signs and symptoms, right? Side effects, et cetera, right? Everything's been going good so far pretty much with these vaccines, right? But they need to know, and the only way they know is with what vaccine did you give, that the next thing we saw was a claim for that patient with who was had a fever and was admitted to the hospital, right? So yeah, so that's that. In psychiatry, now this isn't a new code. I don't know if there were any mental health professionals listening, but 90785 is an add-on code that's been around for quite some time. I'll be very honest, I had never really noticed it before, which I feel badly, because some of the psychologists or psychiatrists that I work for may have benefited from this code, but I learned something. So this is interactive complexity, and it's an add-on code, so it gets reported in addition to whatever the code is for the primary psychotherapy, interactive psychotherapy procedure. So they've revamped the guidelines though. So for any of you who are psychiatrists, clinical social workers doing mental health, or psychologists, you need to go in and read the whole thing. So because it's actually telling you what are the circumstances when you can use it, right? That it refers to specific communication factors that complicate the delivery of a psychiatric procedure. And there are 4 qualifying circumstances, and one of them is the caregiver's emotional or behavioral affect that is interfering with the caregiver's understanding and ability to assist in the implementation of the treatment plan, right? So, and there are 3 others similar to that. So that I found very interesting. I love it when there's a code that's been around for a long time and I'm going, oh, I didn't know that was a thing. I love learning. All right, dialysis and end-stage renal disease. Some parenthetical note revisions I noticed, because there are some new category 3 dialysis codes. So again, any section that you know you bill from, you need to look at the guidelines, the parenthetical notes. There may not be any new codes, but there may be new stuff you need to know. So there may not be any new category 1 codes for dialysis, but if you were to go look at the codes that exist, there aren't that many, and look at the parenthetical notes under the codes, you'd actually see something pointing you to a new category 3 code, right, for dialysis. So, right. And then just a note to also tell you, hey, if you're reporting the monthly ESRD services, don't do that for principal care management within that same 30-day period, right? One or the other. Ophthalmology and otolaryngology. Couldn't find any new codes in this section or anything revised for ophthalmology. There is in the surgical section, all right. And for ENT, there are guideline revisions for audiologic function tests. Some codes have been deleted, and the way the battery of audiologic function tests don't even include certain things anymore. So the guidelines had to be revised. And plus CPT has made it really clear that audiometric tests, the hearing tests such as, first of all, that hearing tests such as whispered voice, tuning fork, etc., are not tests that support a code. That's just part of the evaluation and management evaluation. And also that these codes are intended to be bilateral, both ears. But if for some reason these tests are only done on one ear, use modifier 52, right? To show, not just LT or RT, use modifier 52 for reduced service. Cardiology, you'll be shocked to hear that in the medicine section of the book, cardiology has changes. Cardiac cath guidelines have been changed due to new codes, right? There's all this whole section for congenital heart defects and new codes that exist. So there are guidelines helping you understand what's a congenital heart defect versus an acquired heart defect, et cetera. So anybody doing cardiac caths need to read these guidelines, check these new codes. There are new category 3 codes as well. So correlating those with the category 1, they are not automatically exclusive of each other. Cardiology really needs to pay attention to the CPT code each year. And just so I didn't forget to reinforce it, think about spending a little bit of money to get the CPT Changes 2022 book, right? It's well worth the investment. A couple of other things, sections that aren't big enough to really have a section, outpatient and pulmonary rehab. There's some new codes there. There's this, I mentioned this at the beginning when I was briefly talking about the remote physiologic monitoring treatment management services. There's a whole new set of codes, so a whole new section for remote therapeutic monitoring. Now you can read this, but I'm very honest, I'm not quite sure what it is. I can't wait to see somebody put out a better example, but with what I have garnered, right? These codes are intended to monitor services representing the review and monitoring of data related to signs and symptoms. So the remote physiologic monitoring has to be that there's an FDA approved medical device, right, that is transmitting data, right? So my pulse rate, my pulse ox, et cetera, right? That to the practice, to the doctor. And yet, since those codes started, I've had physicians say, so Jean, can I use them for monitoring a patient's pain scores? And if the pain treatment plan that I've developed is actually working? And I've had to say, no, it's not for that. But I think these codes, these new remote therapeutic monitoring service codes, 98975 through 81, I think that's what these are for. Because as I read the CPT Changes 2022, for this section, which trust me, I really needed, they give examples of things such as monitoring of data related to signs, symptoms, and functions of therapeutic response, with the example being musculoskeletal or respiratory system status or therapy adherence and therapy response. And I went, bingo, that is liable to be that type of monitoring, right? So, but you need to know, again, just like the other codes, they're time-based, et cetera. You may find that really I've been doing this. There's now a code I could get paid. So if you had that, really, I've been doing this thought, make sure that you go look at this section of the book. All right, category 3 codes. There's a buttload of them, if you remember from an earlier slide. But just to give you an idea as to, so what's in here? So there's a new code 0650T, programming device evaluation remote of subcutaneous cardiac rhythm monitor system with interactive adjustment of the implantable device to test the function of the device and select optimal permanently program values with analysis, review, and report by a physician or other qualified healthcare professional. So that patient who has the an implant, a loop recorder, something, possibly even, I'd actually have to go to see if it's in the CP changes, if it mentions which devices. But is it that pacemaker? So I don't go to the doctor's office. I don't go to my electrophysiologist's office to get my pacemaker programming done. But a tech comes to my house, brings the electronic device, hooks me up to the device. The doctor is wherever the doctor is, but definitely remote, right? And maybe there's a FaceTime or whatever, and everything is done, the adjustments, et cetera, remotely. The patient hasn't gone anywhere. They're sitting in their kitchen, right? And then, of course, the parenthetical note telling you not to report that code with these other codes, right? So these other codes would give you an idea as to, okay, if these are services the patient comes to the office for, if I'm doing it remotely, I should then be able to report 0650T. So good, I think, example of the importance of checking this section of the book. So subcutaneous cardiac rhythm monitors, to continuous recorded EKGs, iterative adjustment of the device. So for test the function, selects the optimal permanently program, including analysis, review, and report. So do remember, if your doctor goes, oh, awesome, I've been approached by, oh, I don't know, Medtronic about doing this, right? Now there's a code to report it. I'm there, right? Know that it includes not only the doctor's review and his or her analysis, but and a report, right? So it means the doctor has developed something. But just, I think, a real good example as to the importance of looking at your category 3 codes. Okay, modifiers. There have been some changes and additions. So if you're a pediatrician and you treat infants less than 4 kilograms, there's been a change to the modifier 63. And it's really to make sure that it's clear what codes you can report this to, because obviously there's an increased complexity for an infant that is that tiny. So letting you know that it only applies to the codes from 20100 through 69990. So only the surgical section of the CPT, right? From musculoskeletal to the end. No evaluation and management, not anesthesia, not imaging, et cetera, right? So that modifier is 4. There's a new modifier 93 that I want to make sure that people understand how to use, because I'm trying to figure this one out. And this will not be in your CPT code book because it was approved by the AMA the end of September. Got published to their website, I think, on December 30th. I'd like to think that you all had your books before then, but they were sure as heck printed before then, even if you didn't get yours yet. But it was effective January 1 this year. And I've given you the URL so you could go get this information yourself. But this modifier is synchronous telemedicine service rendered via telephone or other real-time interactive audio-only telecommunication system. And you can read the rest. And I remember when I looked at it, I went, okay, so when do I use this? Not when the patient's at home and I do an evaluation and management service, telephone only, because I don't report an office visit for that. There are those telephone only codes, 99441, 42, and 43. So I shouldn't need the modifier 93, but maybe I do, right? I'm still waiting to see what CMS says about this, so that CMS knows that even though the code says it, that it's telephone only, that it was though telemedicine, telephone only, right? Then there are also codes on the list of covered, i.e. payable, CPT codes to be covered under telemedicine. There are codes that are, not all of them, small handful, that are payable if it's audio only. One of them is care plan, advanced care planning discussions, 99497 and 99498, right? So if I was to do the advanced care planning via telemedicine, audio video, I'd report the 99497 and modifier 95 to let the payer know, yeah, I did this telemedicine, patient didn't come to the office. But if I did it telephone only, I would then report modifier 93. Did it via telephone. As far as I know, there is no payment differential with any of these, right? So time will tell. Again, it's only the 20th of January. Then, and you would know this hopefully if you got a HCPCS book, so I'm hoping everybody gets a HCPCS book every year as well. There are about 4 new modifiers that you may need to know about. There's FQ, frank quotient. The service was furnished using audio-only communication technology. And you may just say, but wait, wasn't that 93? This one is only to be used if you're providing mental health services via telehealth, and it's telephone only. And there's a whole, just as cardiology could use its own hour or so in a webinar, so could mental health. FR, Frank Robert, the supervising practitioner, was present through two-way audio-video communication technology. I'm nothing if not honest. I've yet to see anything from CMS as to when do you want this FR modifier on codes? Remember, during the public health emergency, it's perfectly fine to provide services that would be billed incident to, right? So the patient comes to the office for their IM injection of their B12. Obviously, they have to come in, can't do that via telehealth. But the office is basically closed as much as possible, and the doctor isn't there. The CMS is allowing the direct supervision, doctor in the office suite, that's always been required to bill for your staff services under the doctor. They've allowed it to be reported during the public health emergency if the doctor was available via telehealth, audio, and video. So is it then that you report modifier FR? It's only the 20th of January. I haven't spotted a thing about this yet, so watch for guidance from Medicare. And then depending on where you practice, there's also a new HCPCS modifier, FS, Frank Steve, for a split or shared evaluation and management visit. And I'm going to talk about the split or shared visits in a little bit. So if you're in private practice, not employed by a hospital, you're only going to ever report a split or shared visit for hospital visits or nursing home visits, because their split or shared visit is not a thing in your office. You can provide services incident to, or your nurse practitioner can provide services incident to the doctor. Circumstances are met, you get to bill under the doctor. But split or shared visits, as you'll see, is facility-based. So if I'm employed by the hospital, there's a facility charge, right? I don't bill place of service 11, I bill place of service 22 or 19, depending on whether I'm on the hospital's campus or off campus, right? Or place of service 21 because I'm an inpatient in the hospital. And this year, yay, finally, nursing home. If I'm in the nursing home and both the doctor and the nurse practitioner or PA see me today, they have a split or a shared visit, you can now bill that, the right circumstances met, as a shared visit. So anything that is facility-based that is appropriately provided and documented as split or shared, you must use modifier FS. It's only informational. It doesn't change payment. Who you bill under can change payment, right? But it's expected to be on all those claims. There is also a couple of other new HCPCS modifiers, or maybe this is the last one, FT, Frank Thomas. You can read this definition and I'll tell you what it is. So this is really for the surgeon. This is intended, oh, I see a typo. It's not EMO visits, it's an E&M visit. So FT, Frank Thomas, should be added to an evaluation and management service that is actually a critical care service that is provided to a patient within the global period of a surgery when it's provided by the surgeon. So, and as you can see, to help with its convoluted definition, because that definition of FT doesn't read as if it's for what it's for. So I've given you CMS's little quote, as discussed in our calendar year 2022 physician fee schedule final rule. This modifier should be included on a claim in circumstances when critical care services are performed during the global surgical period of an unrelated procedure, right? So I did your gallbladder surgery this morning and this afternoon, I either in the room when you start to crash, your heart failure, whatever it might be, right? It has nothing to do with your gallbladder surgery, right? I render critical care and I'm billing critical care. 21 days ago, I couldn't get paid for that. Today, unrelated to my surgical procedure in the global period, I can be, right? So that's a good thing. All right, ICD-10, that's it for CPT and HCPCS. ICD-10, there's just this one little slide, I think. This again will not be in your code book because this came out 2 weeks ago, maybe 10 days ago. These codes are not effective now. They are effective as of April 1, and they are needed codes. So they've been added to chapter 21, which is factors influencing health. So those the Z codes that if you're primary care, you'll use for the patient who's coming in for their annual wellness, et cetera, right? So there's this new subcategory, Z28.31, for under immunization status for COVID. Z28.310, unvaccinated. So I came in and you're treating me for what you think might be COVID. A secondary diagnosis might be Z28.310, because when you ask me, I said, no, I haven't had the vaccine, right? Or Z28.311, partially vaccinated for COVID-19. So I had my first dose of Pfizer, but I haven't had the second, right? As an example. Or Z28.39, other under immunization status, right? So it's the catch-all. There isn't a code that kind of speaks to it, the actual circumstance, right? So interesting. All right, that's it for codes. Whew, it's a lot for codes. On to the physician fee schedule rule. And there's about a half a dozen things I'm going to talk about. Wish I had an hour for each one. I am going to spend a little more time than you might think on the Medicare enrollment changes, because the changes aren't necessarily what you might think they are. They have, if you're unaware, it could be a significant compliance risk, right? So I hope you will bear with me while I spend a little more time in those couple of slides than you may have thought I might spend on a topic like that. All right, so the fee schedule rule, as you know, the conversion factor went down, which is of course going to have a negative impact on most codes. Say most, not all, because it depends on what happened to the RVUs, right? So if the RVUs went up, that could counterbalance any reduction in conversion factor. But, so not every code is paid less this year. We obviously did get some relief to the 2% sequestration. So, you know, the good, the bad, and the ugly, right? All right, first real topic, split or shared visits. So doctors in private practice in their office have really never been able to bill what's called a split or shared visit. You may have thought you were billing for one, right? But the definition in the CMS manuals had always really said that it was outpatient hospital, inpatient hospital, or emergency department. Those were the places of service where the definition of a split or shared visit applied. So you'll able to be thinking, well, when the PA and the doctor both see the patient in our office, we've been billing a shared visit forever. No, you haven't. You may have called it a split or a shared visit, but it wasn't one because it didn't meet the definition. You should have been billing it under your incident 2 guidelines. So if the PA was seeing a patient that the doctor had seen previously, not a new patient, and was following up on an existing problem, and the doctor also saw the patient while the patient was there, sounds like it might have met the incident 2 criteria, you could bill it under the doctor. So you can only bill what you might think of a split or shared visit if all incident 2 criteria are met. And I think I've got a bullet or something on what that is, so you have a take home in a minute. So a split or shared visit is an evaluation imagine visit in the facility setting that is performed by both a physician and a non-physician practitioner who are in the same group, right? So it's in the facility. And nicely this year, they've added nursing facilities, skilled nursing, or just plain vanilla nursing facilities, because there's never been any incident 2, never mind split or shared visits. One of these days, I'm going to put the SH on the wrong one of those words, allowed in the nursing home. But since CMS has changed it to be a visit done by both providers in the facility setting, they have now added nursing homes. So that's a good thing. And how will a payment be made? So 2 people see the patient, who gets paid? Who do you bill it under? Payment will be made to the practitioner who performs the substantive portion of the visit. This is where it gets tricky. So your doctor goes to the hospital, your nurse practitioner may go in earlier while the doctor's seeing office patients or doing procedures, right? And she's doing rounds, and then you tag along with her later, and your visits are really, really efficient, right? How do you know whether or not you can bill under the doctor, or do you have to bill under the nurse practitioner? That's one of the biggest changes this year, right? All right, so a couple of points. The documentation must be signed by the billing provider. So there's no nurse practitioner or PA saying, Dr. Smith saw the patient with me and he did this, that, and the other, and he agrees with my plan. First of all, there's none of that. And Dr. Smith must sign that. Whatever the note is, must sign it if it's going to be billed under him. The substantive portion this year, and I'll explain why it's only this year, is if the doctor performed let me rephrase that because that was definitely misstated. If the doctor performs the history, the exam, or the medical decision-making, you can bill the shared or split visit under the doctor. And obviously this is important, right? You want 100% of the fee schedule or 85%. Or if you've paid attention to how much time was spent with the patient, you can bill it under the doctor if the doctor spent more than half of the total patient visit time. Now, probably everybody is going, what, when they heard this? We don't pay any attention to time when we're seeing patients at the hospital or the nursing home. And that's exactly what CMS heard, because their original proposal was you could bill a shared visit based on time only, and you use the provider who had performed and documented the greater amount of the time. Well, because CMS heard so much from the medical community about what the heck are you doing? We don't even know how to implement that. They added this 3 key component thing this year. But you'll see the last bullet down here, beginning in 2023, a substantive portion of the visit will be defined only as more than half of the total time. So if you're billing split or shared visits for hospital visits, now nursing home visits, you've got this year to pay attention to the time and how you're going to capture the time and document it, because come 1/1/23, the only way you'll be able to bill under the doctor, if you've done that, you've done it correctly, and it's clear that the physician has spent the majority of the time in minutes. Just in case I have any provider-based folks listening, so hospital-based physicians, where there's no incident to billing, and when your providers, your doctor, your nurse practitioner, PA, both see the patient in your outpatient clinic, what most people think of their office, you can bill under the shared or split visit concept. So even though you're billing an office visit, 99202 through 99215, and there are no longer any requirements for history exam or medical decision-making, that statement in that second bullet holds true. And because it makes no sense, because there is no required history or no required exam in the office visit codes anymore, I actually queried someone at CMS who I've had the pleasure of interacting with through the years that she's been there, as to, okay, did you make a mistake when you said that? And the answer is no. So you're not going to choose the level of the code based on history or exam, only medical decision-making or time, because that's how you choose an office or an outpatient visit code. But how you choose who to bill under in the provider-based or inpatient hospital or nursing home, right? Scenario is either who provided the majority of the actual time, or who did the history, who did the exam, who did the medical decision making. And I'm using the word "the" deliberately. So it can't be that the doctor writes that I saw the patient, saw and examined the patient and agree with the nurse practitioner's plan. No, the exam, what the doctor did needs to be documented. So the physician would actually have to document the exam that he or she did. This is going to be a bear this year, folks. I know it. And how in the world are you going to have a note that shows I'm the nurse practitioner, I came in, I did the history, maybe I did an exam, probably did, And I came up with an initial impression. I ordered some tests maybe. All right, here comes the doctor after hours to do rounds with me, or maybe not with me, but to see the patients much more efficiently. Whatever history or exam that doctor did, that doctor is going to have to document independently. Oh, this is going to be a mess. Enough said. All right, so split or shared visits can be reported for new and established patients if you're often provider based, so that's a good thing. Initial and subsequent visits, both in the hospital and in the nursing home, that's a good thing. So there are a couple of good things here. And prolonged services for that extra time, that real lengthy encounter, was never allowed to be split or shared. So that's good. And if you are billing because you chose the level of service based on the combined documentation of these two providers, make sure modifier FS is on the evaluation and management code. Right? The documentation must identify the two practitioners who performed the visit. The individual providing the substantive portion must sign and date the medical record. So to end this on, because I'm sure most people sitting here are going, wait, we have an office, we go to the hospital, or we only have an office. So how do I keep this stuff straight? So in the office, private practice setting, the only way you can bill for services, only way you can bill under the name and NPI of a physician for a visit that was done by your PA or nurse practitioner is under Incident 2. Incident 2 services are permissible in the office setting. So those who are hospital-based can't even do this, right? So this is those of you who bill place of service 11. And allow non-physician practitioners to bill for services under the supervising physician's number when specific supervisory and clinical requirements are met. The Cliff Notes version, I'm your nurse practitioner. I'm seeing a patient who Dr. Peterson has already seen. I'm following up on Dr. Peterson's plan of treatment. I don't change anything in the plan. I don't uniquely order any tests. The patient doesn't say, oh, and by the way, I've been having back pain that I address. None of that happens. All this is a routine follow-up for the treatment plan that the doctor, the patient's regular doctor has created for the patient. And there's a doctor in the office suite, and I don't change anything. Split or shared services are permissible in a facility setting, hospital outpatient, place of service 19 or 22, hospital inpatient, nursing home, and allow physicians and non-physician practitioners to collaboratively perform E&M services, right? And then, as I said, you bill under the person who provided the substantive care. My prediction would be there are going to be a lot less visits billed, shared or split visits billed under the doctor. Let's see, did I have some final words? Yeah, so you can read this. 2 separate notes, really doesn't matter as long as the documentation is clear and the billing physician provider has signed. I meant to take this out. So NGS is a MAC like First Go Service Options is. This came directly from one of their FAQs this calendar year. You see, it was dated January 4th, right? But this is before CMS sent out the whole, okay, so this is how to determine substantive, yada, yada. I need to take this out because that last bullet, the example, I have seen and examined the patient and NGS saying, yeah, that would count. I couldn't defend that, right? So this is where the consultant is actually going to disagree with one of the MACs. And I bet you that once this MAC realizes that this transmittal that really defines substantive and what's required in the documentation came out just Friday, that they're going to take this question and answer off their website. All right. Anybody doing critical care? There are a couple of good news items here. Critical care was never allowed to be a shared or split visit, right? But it's now facility service, right? And it is time-based. So a couple of things. One, the critical care can be split or shared, the doctor and their non-physician practitioner, if they both provide critical care today, combine the time, bill under the person who provided the substantive time. But also, it's never really been allowed, not by Medicare at least, that 2 doctors could be providing critical care at the same period from 10 a.m. to 10:45 a.m. Only one got to bill critical care, right? Nope. This year, assuming they were both working on two different things, so the intensivist is helping the patient's kidneys not to fail, and the cardiologist is working on the heart failure, right, that the patient's going through. They're both providing critical care to a critically ill patient, both between 10 and 10:45 a.m. They actually both get to bill for critical care. So that's a good thing. And I kind of already, oh no, this is something new. So this is a weird change. So it kind of always was that, yes, you could do critical care and an evaluation management service on the same visit, as long as the patient wasn't critically ill when you did the E&M and blah, 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 modifier 25. Okay, so they've revised that. So yes, you can bill critical care on the same day as another evaluation and management service, but only if the evaluation and management service happened before you provided the critical care service. So I'm doing rounds and I'm the cardiologist, poor cardiologists, they got picked on in CPT and I'm picking on them. I'm doing my cardiology rounds and the patient is doing okay. So I bill my 99232, let's just say. And then later when I'm back in the hospital or I'm off on another floor somewhere with another patient, I get called, the patient's crashing. Now I provide 50 minutes of critical care. So I can bill for the hospital visit with modifier 25 and the critical care, assuming all the criteria are met and the time, et cetera. But the reverse is not the case. So I provided critical care and then I came back in the early evening to check on you. You don't need any critical care. It is medically necessary that I see you again. I don't get to bill for that second visit. So that's kind of weird. Oh, well, I just deliver the news. And then for the shared or split critical care, right? The nurse practitioner and the physician both doing it in the same day. You bill again, just like any other shared or split visit under the provider who performed the substantive portion of the service with critical care. It's the amount of time, right? And again, the billing provider must sign and document the record. And modifier FS needs to be on the critical care code if it's billed as a split or shared claim. Talked about the other modifier. I think I talked about all of that. Next topic in the rule. So this was nice for the PAs. So physician assistants, yes, they must function under the supervision of a licensed physician. But for some reason, maybe because of that, right, they've never been allowed by the Medicare program to set up their own practice, to work independently. I can remember in the past having an orthopedic PA call and ask me, hey, Jean, a couple of other PAs and I were talking that we were wondering, could we set up a practice where we would contract to some orthopedic surgeons to do their surgical assists, and we could bill for it. And I had to then tell them, sorry, you can only be credentialed by the Medicare program and probably most other payers as part of a physician practice. You don't have the right to bill independently for your services. Sorry. Well, if I got that call tomorrow, I'd have better news, because now CMS is allowing physician assistants to get credentialed pretty much the same way as any other non-physician practitioner, like a nurse practitioner, right? No, there is nothing that you have to do right now, because you're maybe sitting there going, oh, wait, we've got two PAs. Do I have to change their enrollment? Nope. Nothing to do right now. As a matter of fact, for the time being, even if you started a new lady PA with the practice, you wouldn't change the paperwork. You'd still just do an 855I to the Medicare program to show them where they're working now. You would not do a reassignment in 855R. The system isn't ready for that. Eventually you'll have to, but PACOs wouldn't know what to do with an 855R for a physician assistant, right? So nothing for you to do, but nothing really for any of you to think about unless you're a physician assistant. You may be sitting there smiling. Okay, this is the area that I want to spend a little bit of time. So the Medicare enrollment changes have nothing to do with what you have to submit to Medicare, have nothing to do with the forms, has to do with CMS's ability to deny or revoke Medicare billing privileges. So as you can imagine, although most doctors don't read the information where they sign that, yeah, I agree to everything, they've assigned to a page, page and a half of stuff that they swear they've never done wrong and never will, right? It's always been, for as long as I can remember, that you, the practice, any healthcare provider organization, could not employ someone who was excluded from the Medicare or any other federal healthcare program, right? Someone who had committed an act that was fraudulent, et cetera. I'll show you the reasons in a minute. That you can't employ that individual. But from an enrollment perspective, to just and because if you did, you might have to pay fines and penalties. But there was no real penalty if you hired a biller who had been excluded. And don't think it doesn't happen. I could talk about a small group in Broward County who self-disclosed to the government when they realized that the brother of one of the doctors that they had hired was excluded from the Medicare program for some scheme he had been involved in a couple of years earlier. So check average references for everybody, please. And so this whole thing with revoking your entire practice's billing privileges didn't apply to that other little downstream person. It applied to, the physicians, a supervising physician, the authorized official on the forms that you submitted, the delegated officials, et cetera. So in the 2022 physician fee schedule rules, CMS has expanded its authority not only to clarify or strengthen certain components of the enrollment process for preventing fraud and abuse, but also to enable CMS to take further action against providers and suppliers who do have anybody involved in their practice who's been excluded. This slide is all from the rule. I have added the underlining for emphasis, so you see what I mean by they've expanded it. Billing specialist, your accountant, human resource specialist. So billing specialist, I bet you pay them, your coder biller, the CMS is just calling it a billing specialist. I bet you that person's payroll comes from money that you got from Medicare, right? Oh, sure it does. Your accountant who does your taxes, I bet the check you write that CPA firm, that money came from Medicare payments, right? This is what will not be allowed any longer. Not if you want to maintain your billing privileges, or if they're doing a check on an existing, or if they're doing a check on a new application that they find any of this out, right? So other health, and it really means anybody. The new language means other healthcare or administrative or management services personnel. Nobody, right? So how do you avoid this? So you need to check the OIG's list of excluded individuals. There is a freely available, some of you are probably sitting there going, yeah, we do that, part of our compliance program. And many more of you are probably going, what? So the URL is there. There is a freely available, you don't need anybody's permission to check. You could put my name through it. List of folks who have been excluded and are currently excluded from participating in any federal healthcare program. You must check everybody that works for you, including some other folks that aren't on your payroll. I have a list in a minute. Before hire, I do it for all my staff. I always say when I do this talk now, I bet you 9 out of 10 employees don't realize that as part of the new hire process, I'm going up to the exclusions list and making sure they're not on it, right? Because you pay the doctor's offices who are my clients, you're paying me with federal funds, right? Acevedo Consulting gets a check that was generated by Medicare claims, et cetera, right? So that means me too. So when do you do this? At hire, so initially, and routinely thereafter. A really best practice is monthly. That's kind of hard. It's not required, right? But that's what the OIG would tell you, monthly, because they update their list monthly, right? So, but routinely, I do it at least once a year, right? Sometimes I go, wait, it feels like it's been a while, and I go and I do it for everybody, and then I save the results. And I realized, oh, I just did that 5 months ago. So better safe than sorry. So what gets somebody excluded? Here's a list for what's called mandatory exclusion. The Office of the Inspector General has no choice. If you've been convicted of a felony substance abuse or alcohol abuse, patient abuse, fraud and abuse, sexual assault, or if you're a licensed healthcare professional and had your license revoked for any of the above, you're excluded for a minimum of 5 years, up to the end of your life. Permissive, so maybe it's not 5 years, definitely probably not for the rest of your life, maybe 3 years or so. A misdemeanor conviction or a license revocation for the same things. And then here's the one that people don't think about. In fact, I was shocked when I first realized this. Default on a federal student loan. I was doing a corporate compliance education for a practice up in the Northeast one year. And when I got to this on a slide, the doctor whose practice it was shot up from his chair, came over to where I was. It was a large room. It was a large group. Grabbed the microphone and looked and said, okay, before any of you default on a federal loan or your federal student loans, please come to me. And I knew what he was basically saying is, if I can help you make the payments, I will, but don't want to find out that you're excluded and I, the doctor, have billing issues. So who do you check? Everybody that you write a paycheck to. Every independent contractor. There are no free passes. Yes, the lead doctor, that doctor gets checked, right? You have a PA, a nurse practitioner, front desk staff, your scheduler, your biller. You have a billing company. Who works your account and who's the owner of the billing company, right? You have a coding compliance firm, folks like me, right? You have to check them. Here's a quote from the OIG's website. Thus, a provider or entity that receives federal healthcare funding, which is everybody's listening today, may only employ an excluded individual in limited situations. Those situations would include instances where the provider is both able to pay the individual exclusively with private funds, that ain't happening, or from other non-federal funding sources, that ain't happening, and where the services furnished by the excluded individual relate solely to non-federal program patients. Okay, I've managed to have a bank account that is only, it's only workers' comp money in there. It covers your payroll taxes, your health insurance part that I pay, et cetera. And your payroll only comes from that account. Nobody's going to do that. So it's impossible. And why would you be in compliance, right? Why would you want to do that? Please. So you got to check. Now, here's how easy it is. So I did a screen capture. When you go to the URL that I showed you, as you can see, search for an individual, enter the last name, enter the first name. So I put my name and I hit search. And here's what I got. No results were found for Acevedo G. This screenshot is what I copied a PDF and I save, and all my personnel files are electronic. I don't have a filing cabinet in my office. So I print these off to PDF and I save it, or you can save it in your compliance records or whatever. I don't care if you have a compliance program, formal or not, or if your practice is just trying to do all the right things right. This is one of the things that you must do, right? And again, do it for everybody. Now, you've probably not done it for anybody. So if you've got 15 employees, yeah, you need to take the 20 minutes, maybe tomorrow before you go home, and do this for all 15 employees, right? If you have a large practice, there are companies that do this, right? So it's a must. Otherwise, with this new authority to revoke and deny Medicare billing privileges, you really take a chance that isn't worth it. All right. If anybody has physical therapy in their practice, or if you refer to physical therapy, you need to feel badly for these folks. Due to the Bipartisan Budget Act of 2018, so Congress has had this coming, making CMS do this for a few years already. CMS has to reduce the payment for physical or occupational therapy services by 15% for services billed to Medicare that have been performed in full by an assistant, so a physical therapy assistant, occupational therapy assistant, or where the assistant has provided most of the time for these services today. So almost like the reverse of substantive shared visits, right? And the way Medicare will know is that the modifier CQ for physical therapy or CO for occupational therapies would be on the claim. And if CQ is on the claim, for example, so 97110, 1 unit, and the modifier is CQ, oh, that was performed in part or in whole by a physical therapy assistant, so we're only going to pay 85%. The de minimis threshold is the more than half the time rule that I was talking about earlier, right? So that would be most physical therapy services are 15-minute units. And if the assistant provides 8 minutes or more of any one of those units or in full, the modifier must be on the claim. The provider is going to get reimbursed 85% of the fee schedule rather than 100%. This is a tough one. I'm not sure what started Congress to put this into the Bipartisan Budget Act of 2018, because physical and occupational therapy practices are not cash rich. They don't get paid a bundle for these therapeutic codes. It's going to be difficult. It's going to have an ill effect, I believe, on the assistants' careers, or at least their salaries. I mean, I can't take you couldn't take a 15% hit on reimbursement and pay everybody the same, right? I mean, it just doesn't work that way. So you've got some slides in here showing when you would not need it, right? So there is no therapy assistant that's involved in a unit of service. Well, what happens if there are 2 units, et cetera, that I'm not going to spend time with because I typically don't have that many therapy providers on these talks, but I wanted to make sure you had the information, right? All right, telehealth. Okay, so nicely, and I don't remember if I updated these slides, if I have it later, nicely on the 14th, I think that if that was a Friday, Secretary Becerra, HHS Secretary Becerra extended the public health emergency for another 90 days. So we're good until April 16th, 2022. And by we're good, it means that the telehealth that you've been able to provide, that you never were able to provide before COVID, you can still do, at least through mid-April, right? So that's a good thing. There are some changes. So if you're a mental health provider, psychiatrist, psychologist, et cetera, you can do some of your services telephone only. Remember, I even showed a modifier for that. But any mental health services provided telephone only, the clinician must document why it could not have been audio video, right? Lack of internet access, patient doesn't have a smartphone or doesn't know how to use FaceTime or WhatsApp or DoxyMe, et cetera, right? So some changes there. Mental health needs to pay attention. And then because, and this I'm very happy about, right? So because CMS has actually realized that they'll never put this genie back in the bottle, the genie being telehealth for anybody, right? Because remember, before the pandemic, why weren't you doing telehealth? Because it was only payable if the patient was in a rural area and the patient went to an originating site in the rural area, either a doctor's office out in the boonies, right, or a critical access hospital, and you were in your office, right, the provider's site, and both of you billed, right? The doctor billed for his professional services, the originating site billed for their technical services, you're both on the same technology, et cetera, right? That still exists. But there's no way we're going back to only that. There was a study that one of the CMS offices showed on one of their educational things that I finagled my way into about a year ago, that showed that before the pandemic, in about, I don't remember if it was a calendar year or a 6-month period, there were a total of, I think it was 14,000 telehealth visits for Medicare beneficiaries. In that same time frame, last year or 2020, there was something like 13.5 million telehealth visits, right? There is no way on God's green earth we're going back to the way it was. Plus, it's a good thing, right? Is it perfect? Of course not. Would anybody not want any telehealth? I don't think so. So CMS wisely said in the rule, okay, there were certain services that really were supposed to end last December, or definitely when the public health emergency ended, so which would mean possibly April. But we want to give ourselves time to see, okay, what do we really should be doing long-term, and give Congress time to figure out, okay, this genie's not going back in the bottle. How do we want to change the laws? So we're going to allow them through December 31st, 2023. So almost another 2 years, right? So that's really good. So if you're wondering whether or not we'll go back to the old telehealth, which means you don't do telehealth, I doubt it. And I've been trying to follow what the folks in Washington in Congress are doing with, introducing bills, et cetera. And there is one, I can remember the Republican Congresswoman, but I can't remember who the Democrat was, but Congresswoman Liz Cheney has co-sponsored with a Democrat a bill that does the two things that to me are the most important for doctors. And if they're the most important for doctors, that means as a patient, they're probably good for me. One is payment parity. Hallelujah. Why would you get paid any less just because the patient didn't come to your physical office? No, you don't need table paper or gloves if I'm just on, the EMR app that allows you to do audio, video, or something, right? But you've got this technology to worry about, et cetera, right? There's still other things that incur an expense. So payment parity. And the other was to permanently eliminate the rural district requirement, right? So yay, right? So if there's something that you want to, or if you have the bent to support bills or something that are done in Congress, try to find that one. It's the only one I could find, the one that's co-sponsored by Liz Cheney, and darn, I feel so bad that I can't remember the Democrat's name. Anyway, that has the two most important things in it. So, all right. Let me see what else was I round that in. So virtual check-in. So in 2019, should tell you it's before public health emergency, so it has nothing to do with telehealth really. This virtual check-in code G2012 came out. This is a service that Medicare started paying for back in 2019. That if the patient called and the doctor or the nurse practitioner, the PA actually spoke with the patient just to determine next steps. So it's, hey, Sharon, can I speak to Dr. Peterson today? I think I'm having a side effect from my medication. So Dr. Peterson calls me back later in the day. We spend 5 or 10 minutes on the phone, and she tells me, no, I think you're good. It has nothing to do with the new medication I gave you, but call me on Monday if you're not feeling better. Virtual check-in. Just looking to see what the next steps might be. 5 to 10 minutes. G2012, billable service. Those calls happen all the time. They should hopefully be being billed. In the middle of last year, CMS created G2252, which is the same thing, only longer, 11 to 20 minutes, because they heard from physicians that, wait a minute, this virtual check-in stuff is really good. It comes in handy because we do this all the time, but what makes you think we're off the phone in less than 10 minutes, right? So CMS created last year G2252 and has made it a permanent code, right? So that's a good thing, right? It's another good thing. I don't think enough doctors are probably aware of the virtual check-in codes nor are using them. So, all right, so that's a lot of information. I hope there's at least one pearl for everybody. What do I want to do in summary here? So when it comes to codes, if you haven't already, pull out your CPT code book, at least. Not only to check that you haven't missed any new codes, you don't want to wait till the doctor gets a denial on something, right? Or you find out that there was this combo code that you didn't know, so the doctor's being under reimbursed for the last 7 months. And read the guidelines and parenthetical notes in those sections of the book that you code from. But I'm assuming that most of you that I'm talking to are administrative staff, whether the manager, coders, billers, et cetera. Make sure that the parenthetical notes and guidelines in particular are shared with the providers. It's really important. And make sure that the folks who are in your practice who also need to know, so the rest of your coding and billing staff, right, actually get to know all this information. Whether you have a formal, I think I said this, but it's worth repeating, a formal compliance program in writing with a manual, annual training, chart audits, et cetera, whether you have that, which you should, by the way, but whether you have that or not, you're just trying to do all the right things right, check the OAG's exclusions list. Now, before every hire and on an ongoing basis, and keep it. with, if you have paper files, print everything out. If you have everything kept electronically, save to PDF and save them in the individual's personnel files or the vendor's folder, et cetera. And if you're sitting there going, well, we have a company that does background checks on all our staff, don't assume that they're checking the OIG's exclusion list. Very few of those firms work in the healthcare field. They don't even know there is an OIG's exclusion list. So check to see whether or not that is indeed something they check. Ask for proof, right? And if they're not, then either see if they won't add that to their repertoire of services or just do it yourself. Educate all physicians who work with non-physician practitioners who see patients in the hospital as split assured visits, or if you're or the nursing home, or if you're provider-based practice on the new definitions and everything. And of course, your coding and billing staff, make sure they know. You don't have to be a certified coder to look at a hospital visit note and see that, okay, so Jean, the nurse practitioner, documented she saw the patient for 15 minutes and Dr. Peterson saw the patient later for 25 minutes. Oh, I can bill under the doctor, right? So make sure everybody that needs to know knows. You mark my words, we're going to see audits on split shared visits. I just know we are. And whether you remember to use the FS modifier or not, I don't think using it is probably going to be less of an indicator for a chart audit than not using it when the payers know that you have one or more bid levels. How do they know that? You credentialed them with Medicare, et cetera, right? So, and they don't see any bills in the hospital. Makes sense. So consider, if you're a specialty practice, implementing principal care management, right? Again, not to pick on the poor cardiologist, but I mean this in an affectionate way. Cardiologists always have patients who are not stable and need to be managed outside of the routine visits, right? So, and the Medicare program really wants physicians to provide chronic care management, principal care management. Remember, they created this. These all started with HCPCS codes. Means the government created codes so you could bill for this. And chronic care management is one of only 2 or 3 covered services, Medicare covered services, that you could go to the web and find a whole page on only that. You can't go up and find a page on physical therapy with resources for the patients and signs for your office that you could print, et cetera. But if you went to the chronic care management website, you could find all of that for your resource, for the professionals' resources, patient resources. What's the URL? It might be go.cms.gov/CCM, something like that, right? So the government wants you to do this. They commissioned a study a few years ago that showed that patients are more satisfied, the quality of their care is better, i.e. they're not going to the emergency department or readmitted to the hospital as often if they're getting fairly routine care management services. And shocker, because that's not happening, overall Medicare payments are going down. Yeah, the doctor payments are going up because physician practices are billing for a service that didn't exist more than about 5 years ago. But that's small, right? A $40 payment for some type, or $60 or $80 payment, depending on what you're doing. Payment every month for each patient for care management pales as opposed to the 10 or 20,000 you're paying for every emergency department visit, right? So, and then keep on the, yeah, I didn't change this, right? So we did get I have to update this slide before I do this presentation again. The public health emergency did get extended, so it's now through April 16th. And you can look at the public health emergency. Oh no, that bottom URL needs to be moved out a bullet. That's the list of covered telehealth visits, preempting any question on that. And that's it. All right. So let me see. I have one question in the Q&A. Let's see what this is. Hello, Selena. All right. For the split shared facility setting visits, they can be billed under the provider that spent the most time with the patient or based on history exam, MDM. But would the main provider have to do all 3, the history exam and the MDM? So basically, that main provider would be doing the whole note, history exam, medical decision-making. Sorry if this doesn't make sense. Oh no, it makes sense. So if our physician assistant did the history exam, medical decision-making, we would bill under the physician assistant Because right now we're billing under the provider, even when the PA does the note. Okay, great question. You packed a lot into that question, but this is the type of question I know I'm going to get about every day now for the next 6 months. So you were paying attention, so kudos, thank you very much. And the answer to your real question, the crux of your question is, okay, so if we're not using time, which who the heck is using time, right? So we're not using time. Does the billing provider, so the doctor hopefully, have to do the history and the exam and the medical decision making? No. The doctor has to do only one of those. Now, you and I could probably spend the next 20 minutes talking about how is just doing the exam the substantive portion of the visit? Isn't the substantive portion coming up with the impression and plan and considering the risk to the patient, all that? Well, apparently not, at least not for this year. So if your doctor documented a physical exam, and for a hospital visit, the extent of the doctor performed physical exam could support the exam required for the code. So what the heck did I mean? So it's an initial hospital visit. The PA goes in, does a complete history, complete review of systems, past family social history, et cetera. Does a partial or complete exam, whatever the PA does, and has an initial impression, right? Doctor comes in later, doesn't do much of a history, reviews the PA's history, but performs a complete physical exam, right? The doctor wants to know, okay, this is what I'm hearing, this is what I'm feeling. So documents a complete, comprehensive physical exam. And if the medical decision-making is, say, of high complexity, regardless of who documented it, you could bill a 99223 for that initial hospital visit, comprehensive history, comprehensive exam, medical decision-making of high complexity, equates to a 99223 initial hospital visit. You could bill for that since the doctor's one component, exam, met the requirements of the code, in this case, comprehensive. That's what this calendar year CMS is considering an example of the substantive portion of the visit. So I'm hoping, Selena, that gave you an answer that since the whole situation is convoluted, that is helpful to you. All right, so is there anything else in the
There's two other questions.
Yeah, I'm going into the chat to see if there are
Yes.
things in here, Cynthia.
There was one early on saying, is the FT mod replacing 24
Yeah.
mod?
I see it, yes. So is the FT modifier replacing 24? No. So the FT modifier is only used by the surgeon who provides critical care to the patient in the global period unrelated to the procedure he or she just did. So it's not billed, it's not a visit code, right? You're going to bill modifier 24 on a visit in the office, and the patient comes in within the global period of whatever procedure you performed. And the office visit is not related to the procedure, right? So modifier 24 to get your office visit paid, or modifier 24 to get your hospital visit paid, because that's what happened, right? FT is only used on the critical care code should you provide critical care to a patient unrelated to the surgical procedure within the global period. All right, let's see what else. If I scroll down here.
Doreen.
Whoops. I hate the new mouse on my new computer.
Yeah.
I love the computer, but I hate the mouse. All right, so into it, can this be used for removal of staples sutures the day after? So I'm not quite sure what this is. So I see from Doreen, you've got an integumentary. Can this be used for removal of staples sutures the day after an ablation or Watchman procedure? So I don't know what this is. So, but removal of staples or sutures from a procedure that your doctor did within the global period of the procedure is not a billable service. So hopefully I answered it anyway. So let's see if I'm careful with this mouse. If I can. Do you see the Q&A? Okay, wait. No global. No global. Oh, no global. Oh, so there's typically, thank you, Doreen. So there's typically no, it's probably, I doubt that there is a procedure code for what you're talking about. So it would just be a low-level visit. That's how I would code it. I don't think you're going to find a CPT code for removal of the sutures or the staples for those procedures. Okay, come on, system. Okay. Sorry, folks. Like I said, my new computer is fast. I love it, but still getting used to the very sensitive mouse. Oh, I guess maybe that was it.
I think she said, okay, thank you.
Yeah. Okay, good. That's a good thing then.
Yeah. Well, thank you, Jean. Are there any more questions?
Yeah.
All right.
Yes.
Yes, I hear a yes. Speak up, young man.
I raised my hand, but I don't see anywhere on the screen, and I was trying to post the question. Hi, Jean. Ms. Abby Barron speaking.
Oh, hi, Dr.
I'm
Barrett.
still dealing with last year's prolonged office visits that you had originally enlightened me about. And depending on which licensed crook insurance company that I'm sending my bills to, they all unilaterally deny. So one will deny the 99417, the other one will deny the G2212, and then when you bill it back with either or the codes that they did deny, then they pay, then they don't pay, and this just drags on. And this, to me, it gives me a bilious taste in my mouth that just lingers, just thinking of the fact that I have to take care of patients, spending an inordinate amount of time because I'm not using non-medical people, non-medical meaning a nurse practitioner, physician's assistant. I do it all, so I spend the time, and I choke knowing that I may or may not get paid, which is overwhelmingly documented in my office notes that are written that clearly support everything that I've done. And I go back and forth. Top of the list of the crooks is United Healthcare, Humana, and then Aetna on that level. And depending on the person's insurance policy, they'll pay or not pay, even from the same insurance plan. So I'm just curious if you have any more insight into all of this, or this is just the way it is and you got to suck it up.
So, thank you for the question, Dr. Barron. So it is just the way it is, but I don't believe you have to suck it up. So here's the thing though, without seeing the documentation myself, I don't know if they have reason to be denying in any of these instances, right? So are you still the president?
No.
Huh?
No. As of November,
you stepped down, right? So in appreciation of your service to the medical community, if you'll give me 2 notes, redact the patient information, right? So we don't have to go into HIPAA, anything, right? And that you billed, that you sent in the documentation and they denied. Let me look and see if I can tell you.
I've already sent that to you last year. I first sent it to your son.
Oh, okay.
And then I got an email back from you, if this didn't work, try that. But I never got a comment on your critiquing my office notes. And I'm most curious because I spend so much, I'm treating paper at night. I'm sorry. I spend, more than 50% of my time making sure that every I is dotted and T is crossed, for whatever kind of recovery audit contractor that might want to try and, shake me down, or anything else. And, I did send it to you last year. So
okay.
If you want me to do it again, I'll do it again.
Yeah, right. For something that's current, right? And do know though, and I don't know how much time you're spending, right? But remember, for your office visit coding, as of 1/1/21, you choose based on the complexity of medical decision-making or how much time did you spend and document that you spent today for the patient. Pre-visit work, visit with the patient, and after, documenting, etc.
You mean I actually have to parse out, okay, I spent an hour before the patient showed up, an hour while I spent the patient. And
No,
then
no,
an hour
no, no.
after.
Nope. So visit time, 75 minutes spent reviewing prior notes and labs, seeing the patient, documenting in the medical record, right? Just the lump. You don't have to parse out each one.
It is in, I'll actually even read something. I just finished. I'll read you what the rhetoric, because I'm, you know, I'm one that if we're going to have to repeat it again, I might as well do it. This is what I have woven into my office notes on a person. More than 50% of the time for today's encounter was spent face-to-face with the patient discussing the following treatment plan, including but limited to the following: review of laboratory testing, review of radiographic testing results and images, review of consultation reports from specialist physicians, review of patient obtained data, including but not limited to blood pressure, glucose logs, A1C logs, and all other blood tests and weight records. Review of remote patient monitoring and or previous patient-related data, including but not limited to records from other physicians, hospital imaging facilities, discussions with specialist physicians, obtaining past medical records, obtaining the necessary laboratory requisitions, obtaining the necessary insurance-mandated authorizations for any outpatient testing, surgeries, referral to specialists and or prescription medications and or durable medical equipment and or home health agencies and or wound care and or physical therapy, creation of referrals, obtaining any necessary pharmacy benefit manager mandated authorization for prescription medications, counseling the patient on medication concerns, medication instructions, reconciliation of the patient's medications and or nutritional supplements, communications with specialists, transferring records to other physicians and or imaging facilities and or hospitals, creation of records, creation of handwritten prescriptions, creation of electronic prescriptions, prescription profiles and or favorite pharmacy online with creation of electronic legacy files and instructions, transmission of electronic prescriptions to preferred pharmacy, a paper copy of the electronic transmitted prescriptions were hand delivered to the patient. That is every note.
So that doesn't make any sense because you're not doing that for every patient. Every patient who comes in, you do not perform all those activities. So you're looking for the payer to deny based on, there's no way because there's nothing in your note that would reflect. Wait, let me finish. I didn't interrupt you, doctor. Give me the same, right? So that's an either or note. One of the things that I'm always against is anything and or in the medical record. It's a legal document. Everything that you said there better have happened for that patient on that day. If there were no pre-authorizations that were needed for that patient that day, your note should not say it did happen. If there were no doctor notes this time and every single time to review, it should not say it, et cetera. So I would suggest that you tighten that up, because if I was the payer, I would discount that statement because I actually wouldn't believe that this happened, especially if I saw it on multiple patients. Like, no, it's just a macro. So you have to make sure that it actually reflects what the patient got. And if you're using time, you don't even need all of that.
No. I've gone the other route where nothing is documented and they don't pay.
So nothing is documented.
Document this and they don't pay.
Well, so you've gone from one extreme to the other. How do I get you in the middle? How do I get you from nothing to everything thrown on the wall to this is what actually happened today? That's where you need to be. What actually happened today? And it doesn't have to be that lengthy. Just has to be, I always look at time-based notes. Would a reasonable person reading your 3 sentences, would a reasonable person look at that, be internally nodding her head going, because most auditors are female, would she be internally nodding her head going, yeah, that sounds like it took a good 45 minutes, right? So, but you don't help yourself by throwing the spaghetti at the wall.
Yeah. And I actually documented the amount of time that I spent with this patient today too, at the end of the note.
So I have a question, Jean. I'm very concerned about the OIG and physicians knowing that they have to do this. Does
Hmm.
this law depend on the number of employees, or is it a physician with
Nope.
2 employees, huh?
Yep,
No?
it doesn't matter. Yep.
Okay.
If you are accepting any federal healthcare funds, which is every doctor,
Mhm.
right? Because if I'm a pediatrician, I'm getting Medicaid, right? You know, and if I'm adults, I'm getting Medicare, I'm getting TRICARE, right? So if I'm accepting any federal healthcare program dollars, I cannot pay any salary fees to anybody who's on the OIG's exclusion list, whether it's just me and my nurse or it's the Mayo Clinic.
Okay. So are you going to get a hot off the press out that we can send? Or I guess I'm saying, should I send a hot off the press alert to all of my members about this? I don't know if anybody on at the meeting today knew about this. I
Oh,
certainly
I have a feeling not, which is why I put it, but when I spotted it in the rule, I went, oh boy. So, you know, like the Mayo clinics, the Cleveland clinics, they know about this stuff, right? But the private practicing doctors, who are the people that I work with every day and have for 20 some odd years, right? They don't know this. And even if they've tried to implement a compliance program, they may not know this, you know? So it's kind of obscure for people like me, you know? So happy to, there are a few things though, Cynthia, that I know need to get out to doctors. So I've turned off the recording, right? I think I have, but it says it's still recording.